Okay. Good morning, ladies and gentlemen. Welcome to this session. My name is Sylvain Giraud. I'm the head of unit health systems in DG Health and Food Safety in the European Commission. And we're very grateful to our colleagues from DG Research and Innovations to have organized this together, this session together. And particularly to my colleague here, Pilar Aguar Fernandez, who will be our rapporteur and will wrap up the session at the end, and our colleagues. So as an introduction and to understand a bit better who is in the room and who are we going to be discussing with, we have a question for you, and that's the first occasion for you to be using the app. And the question is very simple, is who are you? On the list proposed in the app, where do you come from? What professional background? So you have a few minutes, or not a few minutes, a few seconds to answer the question, and then we can see on the screens, and you probably can see on the app, that we have, for the moment, a quite big chunk of policymakers, research agencies, representatives. I wait for just a little stabilization. We've only 11 answers, but I think that's about where we get. So shall we decide that 15, 16 is an interesting level of representation, and then we will start on that basis that there is an important number of policymakers, representatives, local, regional, and national institutions involved in care organization and care delivery, I guess. So the focus of this session is actually on that, is how research and innovation actions are required to bring the true impact to health systems and support them through the transformation that the systems have to go through to be fit for the future. And of course, the logic of that discussion is also to get to what action would be relevant to develop at EU level, and in particular, in the context of Horizon Europe, to offer these opportunities. So we have four panelists with us this morning, and they will share their experience. In a second, I give them the floor. And of course, after their input, we will have the possibility for an interactive session with you. And for that purpose, I invite you to start sending questions through the app. In the Q&A section on Slido, you can, or in the Q&A session for the event app, or I understand in Slido, you can also enter your questions. Then there will be a possibility for you to rate questions of others, and the most rated questions will be submitted to us and to the panel to exchange views on that. So please start entering your own questions and rating others' questions, and that will be the basis on which we'll start the conversation after the panel introductions. In addition to these, we will also use your collective wisdom, or try to collect your collective wisdom later on through some multiple choice questions towards the end of the session, to try to have an overview of how we feel about those developments. Oh, some competition. So to structure the input of the panel, and we have, sorry, I have to be multitasking, and I'm not so good. Here it is. To structure the input of the panel, we have put together a cycle. Okay, can someone help, because it doesn't seem to be working. I don't know where I have to point it. That's here it is. So I don't know, you can see on your screen, we've put a cycle together, an innovation cycle. So we're going to go through the steps in the cycle. I will introduce briefly the policy context, and then I will hand over, following the cycle, to Enrique, who is the co-chair of the EU Health Network and has a considerable experience in IT, health in Portugal and in EU cooperation. He will talk about needs and opportunities. Then I will continue with Martin, who is professor of European Public Health at the London School of Hygiene and Tropical Medicine and research director of the European Observatory on Health Systems and Policies. And Martin will look at the design of research and innovation. Then we'll ask Esteban to take over, and he will look at deployment and implementation strategies. Esteban is the director of Chronic Gune, the Institute for Health Services Research in the Basque Country in Spain. And to conclude the cycle, we'll look at building evidence with Maureen. Maureen is a professor of economic evaluation of innovations for health at the Erasmus School of Health Policy and Management in the Netherlands. So what are we trying to say with this cycle? We see constantly innovative solutions coming up, but the way they are actually uptaken or introduced in the health systems is sometimes problematic and challenging. In a recent publication, Professor Rifat Atoun from Harvard used a few words that I think are interesting. Is that he said there is delivery of innovation, probably quite a lot, but we lack innovation in delivery. So it's nice to see a technological and scientific breakthrough, or at least the announcement of them. But this is not enough. These innovations, this breakthrough, these changes should be meaningful. They should address unmet needs in the health system. They should, in a way, be needs-driven and demand-driven. They should also contribute to address, support and drive broader transformation processes that are needed to make health systems better fit for the future. In addition, to deliver innovation, we need, as I was saying, innovation in the delivery process. So to address the necessary organizational changes in terms of the work organization, the working methods, the professionals, etc., the IT solutions and so on, that are required to embed the new solution or the new services coming through the innovation cycle. This is not straightforward, and there is a knowledge gap probably in this area that we need to understand better how this transformation, this upscaling can take place and can demonstrate effectiveness. So it requires implementation research, but also implementation support measures to develop and pilot the organizational innovation, measure them, and monitor them, and demonstrate their effect. And for that, we need concerted efforts from different types of authorities, but also from different types of stakeholder communities that would need to be more or better involved in the design of this innovation delivery, leading to some forms of co-designing or co-creation, demand-driven co-creation, involving obviously the professionals, the patients, but also the care providers and the payers. So to be able to enter this cycle, we need first, obviously, to know what we're talking about in terms of overall policy objectives. And in the Commission, we've used 3 words to capture this. It's the accessibility, the effectiveness, and the resilience of the health systems. So I guess I don't need to explain too much. The effectiveness is, of course, that these systems actually deliver the quality of care and improve ultimately, or contribute to improve the health of the population. The accessibility is universal health coverage, quite a topical subject in New York at the UN General Assembly this week. Access to services and affordability for the patient, that's accessibility. And resilience is resilience in terms of sustainability of public expenditure, but also capacity to adapt to crisis and shocks. So to achieve these objectives, transformation and reforms are being put in place across Europe in most of the countries. And in the Commission, we've been following and monitoring those transformations, in particular through a tool that we call State of Health in the EU, with country-specific reports and also cross-country analysis of the trends in the transformation. In the publication we had in 2017, there's going to be a new one in a few weeks, but in the one in 2017, we highlighted 5 fundamental shifts ongoing in health systems reforms, and they're not going to be very new for you, but it's a way to clarify what we're talking about. These are first, the focus on health promotion and disease prevention. Second, the need to step up primary care and shift away from hospital-centered systems. Third, to develop integration of care between health services providers, different levels of care, but also between healthcare and social care. Fourth, to develop and improve workforce to accompany those transformations, but also in a way to plan and forecast the workforce needs better. And the 5th point is about data, new types of data. How can we invest in patient-centered data and health on measuring better health outcomes to better inform the policy making? So this was a hopefully useful way to introduce the policy context. And now, moving along the cycle, I would like to hand over to Enrique to define further the needs and opportunities for innovation. Enrique, please.
Thank you very much for the opportunity for participating. I'm coming from a background I think is relevant for everyone to understand. I'm a medical doctor, internist. I then moved on to doing a PhD in management, and I ended up being the head of an e-health agency. And many countries already have an e-health national level agency, some don't. And when you actually take this position and you see public administration, of course, healthcare systems are very different. Some are more public, some are more diffused in Europe. But really, the challenges are mostly the same. I mean, we know that changes are happening. And often ministers meet and they share, oh, you're doing this, oh, that sounds like a great idea. I'll do the same in my country. And then this is transformation of health systems, but maybe not evidence-based. Sometimes it's case-based or neighbor-based transformation. And when you are working at the IT level, you actually can spot these changes if they are rooted in something logical, because then you can look around and you can talk with researchers and you find the roots of the idea, or when they're just coming out of the blue. Okay? So I think clearly we are at the moment where we do need research and innovation to guide people making decisions on policy. The other challenge that I think is an opportunity, and I'll show that in a second slide, is that currently there is already a significant set of accumulated data. And of course now it's a big trend to talk about AI, but as I normally say, first let's have natural intelligence, and then maybe AI, okay, and then maybe collective AI. And the natural intelligence tells you should use what you already have and build on top of that. And if what you have is paper-based health system, that's definitely something you need to change radically and very fast. And I think there's enough evidence on that. So why doing it now is because clearly we are at what we call digital transformation stages in many, many countries. And I'll give you 1 or 2 examples of that. For example, in the case of Portugal, mortality is now digitally tracked 5 minutes at every 5 minutes, because we have mortality reporting online. Done by doctors in real time. And this meant to change the entire cycle of indication and indicators. there are, as I say, disruptive potential, and everyone wants to jump immediately into, you know, CAT scans and MRI scans analyzed by AI. But, you know, let's, as we say, let's make sure, for example, that every image of a CAT scan is actually available to all doctors and nurses in one country. And why not? And that's work has started last year here in Brussels, across Europe. Okay, so I think these are currently the moment. This is a good moment to do this. And the other thing I would always like to say in these panels, as a Portuguese and as a European, is that when we look to US, sometimes we think, oh, they're so innovative. They're bringing up all these, you know, patents and all of these things. Actually, in terms of system thinking, Europeans are much more advanced. And I would like to just emphasize this. You know, we are connecting our healthcare systems, and if we do that in the next 2 or 3 years, we will be significantly ahead. Just as a contribution from Portugal, we found that we had to write our ideas down regarding big data usage and public health and researchers. This is our document. It's online for consultation, and it's, I mean, of course you can comment on it. It's written in English, and I can tell you that the first comment we got was, why did a Portuguese agency write the document in English? You know, I don't know if they were referring to the Brexit or something, but the point is, of course, if you want to comment something, you want to make sure you comment cross-European. It doesn't make any sense to have a national strategy for healthcare system transformation. Systems are too small to be changed in each border. And therefore, we purposely read the document only in English, and it's available for you to comment. The reason I'm showing this is not vanity, is because if the public administration, if the Ministry of Health in this case, is not telling what type of data do we have available for researchers, what type of questions do we need to solve, then researchers off-go, do their own little things. Sorry to say, but my wife is a researcher. And of course she's bidding for grants, you know, and she tries her best. But if she doesn't know the national policy, how can she bid for a grant that simultaneously pays her fees, her bench fees and her PhD students, as well as produces some useful research? And it's, I think, often the case that ministries don't say what they need. So clearly research and innovation can go into community and clinicians, but also between managers and politicians. Managers, especially healthcare managers, lack reading research results, lack evidence-based decision-making. And even programmers and designers of IT often do not base their new systems in existing, in this case, mostly healthcare informatics kind of work. So to conclude, we are building this concept of a health intelligence lab, which is not do a big plan of, you know, it's a wonderful big data AI strategy. No, what we have decided to do in Portugal is work along these lines, okay, trying to bring together public health agency, the guys doing the genetics, telehealth national center in SPMS, and bringing them all together into thinking together, looking at quick wins. And I can tell you, sharing you a story on a quick win, one of our projects, since 1.5 years, Portugal is funding AI projects with one rule that I think is very useful, perhaps even for European level funding, which is public administration can only get money if they apply together with one research institution, either university or research institution. The same thing, the research institution can only get money if they're applying together with those having the problem or the data. So data owners and problem owners have to be together with problem seekers and problem solvers. And in the case of one of our projects, which was for antibiotic resistance, the first quick win was, your data is so lousy, we cannot research on it. Please go back and get it better. And now I have my team getting the data better because the researchers are saying this is not good enough for us to do the research. And of course, the first reaction, as you can imagine, was not very, very good. People get a little upset when you tell them, you know, all the work you've done in the last 7 years is not good enough for me to even start my work. But that's the conversation you want. So this is one of the projects. AI, we are using AI to detect patterns of prescription based on a very large set, 250,000 prescriptions per day electronically, all stored in the same database for the last 7 years. Not just pharmacy, street pharmacy prescription, but intra-hospital prescription as well. And what do we want to look at? We want to find out who are the doctors that need training, who are the doctors in the regions, in the cities and the councils that need more screening. And a final example of this work was the use of deep neuronal models for the coding of mortality rates. So as I said, in January 14, Portugal was the first country, I presume, in Europe to use full electronic mortality death certification. We now have more than 500,000 in our database, and you can start doing online coding. This is examples of transformation that can only be done in a wise, intelligent way if you work with researchers and innovations, but you have to work with them from the beginning, getting the money, getting the data, and then getting the answers. And thank you for the opportunity.
Okay, thank you very much. So, I want to look at what should really be a very, very simple problem, but one which has been remarkably difficult to resolve, and that's the challenge of high blood pressure. Because when we look at high blood pressure, it's really easy to define. The definitions are out there. We can diagnose people with high blood pressure. We just measure it with a sphygmomanometer. We've had safe and effective medicines from the 1960s. We had other medicines before that were not safe and effective, but we've had diuretics and beta blockers and ACE inhibitors and so on since the 1960s and the 1970s. And yet we still find that in countries at all levels of development, including in Europe, a lot of people are undiagnosed. Many people who are diagnosed have not been started in treatment, and many who have been treated have blood pressure that is still uncontrolled. And more than that, when we look within societies, all of our societies worldwide, we see huge inequalities between urban and rural areas, people with different levels of education, people with different socioeconomic status, and so on and so on. And yet this should be incredibly easy to resolve. So what's the problem? Well, when we look at barriers to the implementation of effective treatments or policies, we find 4 broad areas that we need to look at. The first is whether we have enough trained health workers, whether there are out-of-pocket payments, for example, to those health workers. Are the health workers demanding informal, under-the-table payments or something like that? Often patients are waiting long times because of the shortage of health workers, and when they get there, they may only have a minute or 2 with them. Then there's a whole set of physical resource constraints that we find. Clinics don't have equipment, medicines are unaffordable or unavailable. The third group are the information resources. Do we have simplified guidelines, particularly in areas where patients may not come back repeatedly to get their blood pressure checked? We often ask that we check it, and before we start them in treatment, we ask them to come back a few days later for another check. And do we actually understand the health beliefs that people have in terms of treatment? Because in many cultures, and particularly non-European cultures, but even some within Europe, this strange concept of disease, dis-ease, means that you feel unwell. And yet here we have people who feel perfectly well, and we're telling them that we need to treat them for the rest of their life. And we also say that we're going to give you tablets that may actually give you side effects. Do we understand that? Do people have the adequate peer support, the social networks? We've shown that social capital, trust in institutions, trust in other people, it correlates with blood pressure control in societies that have weak health systems. So when we want to do something about this persisting problem, what do we do? Well, we undertook two systematic reviews, one looking at the system level, one looking at the health service, the interaction between the patient and the health professional. As I've said, often it's asymptomatic. Many people identify disease with feeling unwell, don't understand why treatment needs to be administered forever. And we often compound this because patients who are started on treatment may be told by their doctor, well, before you start, we'd like to take some blood tests, just to check that your kidneys are working and so on. And they say, well, why are you testing my kidney function? Are you giving me treatment that might damage it? And then you get a view that perhaps the treatment actually is harmful. Many places we find worldwide that it's still difficult to get the tablets. So what did we do? Well, this was the result of a cluster randomized controlled trial that we did where we tried to address all of these barriers, and it had a number of elements. So first of all, and this was done in Malaysia and Colombia. So if we don't have enough doctors, then we need somebody else. And we trained mid-level health workers. We gave them a course of training so they would know what to do. But we also made sure that they had a link back to a doctor if they did actually need that additional help. We use combination therapy because virtually every patient with high blood pressure needs more than one class of drug. One class of drug is rarely enough on its own. We found that we saw from the literature that peer support was hugely important. A member of the family, a member of the community that could encourage them and give them advice. And finally, simplified guidelines, which was where the technology came in, along with the automatic sphygmomanometers, of course, but simplified guidelines on tablets. Now, what we could have done is said, here are all the things we need, let's just implement it, but we didn't. And in this study, we spent a long time, we took 6 to 8 months in each country doing a really detailed assessment of the health system. We wanted to identify which barriers were important in which country. If people had health beliefs that were not supportive of treatment, what were those beliefs? How could we address them? How could we understand what people were thinking? How could we understand the barriers in the clinics? How could we make sure that drugs would be available? We didn't succeed with everything. We wanted to bring in a single-dose combination of drugs, a polypill, but the licensing problems are enormous. But anyway, we implemented this in a community study. And actually, it was hugely successful. And why this is important is that many studies have been done to try to improve hypertension in communities that haven't worked. But this brought about a reduction in systolic blood pressure in the control group of 11.5 millimeters of mercury. I mean, that is enormous. And a 10-year CVD risk reduction of over 10% in the intervention group. The controls benefited too, because we all know that participating in a clinical trial is good for you even if you're not in the intervention group. So why did it work? Well, many studies that take ideas that have been developed elsewhere and simply assume they can be dropped in and applied anywhere. And of course, that's largely true with the hard sciences. If you can build a bridge in Sweden, you can probably build a bridge in Burkina Faso. Putting bridges together are largely the same. But we're dealing with complex adaptive systems. And in our study in HOPE4, we had a huge investment in understanding the context. We listened to patients, we listened to professionals in the front line, and we adapted the intervention to the local context. We spent a lot of time doing that. And as we move forward, we're taking this mechanism, this approach forward through the guidelines, the roadmaps that are being developed by the World Heart Federation, in which we're saying it's not just enough to have the tablets, it's not just enough to have the health workers, it's not just enough to have the pharmaceutical supply chain working, it's not enough to have the guidelines, but a major element of this approach is understanding the context and finding out why people don't do what we would expect them to do when we give them all the things that we think they need. Thank you.
So hello, thank you for being here. Thank you for inviting me. I'm going to talk about the experience in the Basque Country on chronic intervention, chronic care intervention, and what we have learned, and also how some of the projects we have been working in have helped us. The Basque Country has, since 2010, been engaged in a clear strategy to try to tip the balance from acute care to chronic care, being chronic patients consuming more than 80% of the resources in the health system, so it was clear that we had to deal with that. This strategy involves a population health approach with risk stratification, but also structural integration and coordination between health professionals, patient-centered care, empowering patients and caregivers, trying to have them more power in the decision-making around their health and their treatments. And of course, all of this being supported by a clear strategy of digitalization of the system and implementing ICT tools, electronic health record, through the whole system. All this corporate strategy, policy strategy, has also been supported by some research. Chronic Unit, the Institute of Health Services Research, has been participating with the healthcare services in different projects. One of them is the CareWell project, supported by DG Connect. And this project tried to evaluate the effect and the efficiency of digitally supported integrated pathways to improve results in the care of these patients. And the second project I'm going to talk about is the Act and Scale project, supported by DG Santé, by the health program, and it had to do with scaling up findings of those previous projects. The first project, CareWell project, involved 4 different areas, and we work with other regions in Europe, and we developed a pathway that achieved coordination between health professionals, established different kind of results, and at the end of the day, after 4 years of project and only 1 year of evaluation, what we found is 3 main results. First of all, the clinical parameters of those chronic patients, multimorbid patients, did not change. There was no difference between intervention and control, but the healthcare services resources consumption changed. We had less accident and emergency visits, less admissions to hospitals, and less length of stay for the intervention groups, the ones that were under this care pathway. And of course, we had more stress to primary care services for the intervention group. So there was a shift from hospital to primary care. As a matter of fact, not all primary care physicians were very happy with the results because no increase of resources. So after that results, we got involved in the next project, the Act and Scale project, which was trying to scale up the pathway from those first 4 pilot regions to the whole of the healthcare services. And to do so, we used a collaborative methodology involving all kinds of stakeholders. In fact, we organized a multi-stakeholder group with managers, physicians, researchers, and everybody to try to decide how to not only deploy the pathway in the whole system, but also scale up and try to increase the number of patients going through this pathway. I'm not going to explain the methodology, there's no time for that, but I'm open to any kind of questions. But what I must say that the kind of approach that we had was an implementation research approach. These are complex interventions, as both of my colleagues have already mentioned, so you have to apply a complex kind of evaluation. I'm sure Maureen will talk about that later. And at the end of the day, the results were that we were able, after, again, 3 years, to extend from 4 areas to 13 areas, the whole Basque healthcare service, from 5,000 patients to 18,000 patients in the pathway. And of course, the end result was not a unified, homogeneous pathway for all hospitals and primary care services. It was flexible, it was adaptable, and with some specific characteristics for each of the regions, but all of them being around the same core, the same indicators, the same kind of monitoring. So what are the main lessons that we have learned on these years? First of all, regarding implementation and scaling up of research findings, the first lesson is that research in health services system has to be aligned with corporate strategies. It has to have the endorsements of the management, of the top management, and it has to be clearly like that, which is in other words, saying the same as my Portuguese colleague has said. Second, you need scientific evidence. If you want to engage professionals and managers, you have to give them clear proof that is an advantage over previous kind of behavior, performance, whatever, and you need that. You have to have adaptability. You have to adapt to the different circumstances of each of the local sites and resources and cultures and so on and so forth. Otherwise, you are not going to achieve that. You have to take into account the learning curve. It takes time, and you have to consider that in your planning process. It's not just, as Martin said, come and drop the idea and being adapted. You have to take care of sustainability. It has to be built over the previous resources pathway, and it has all the new innovation has to be, at the end of the day, embedded into the day-to-day care. You cannot start at something in parallel with the main routes. Of course, it has to be based on good information systems, not only good platforms, but roles, skills, interoperability, and so on and so forth. And last but not least, on shared leadership. All these lessons, what we learned is that you need three kinds of leaderships. You need the strategic decision-making leadership with managers that can speed up the process. You need the technical, clinical leaderships for professionals really being involved. But you need also the research leadership, the methodological leadership that sometimes is very useful to solve some of the issues, some of the problems that can be happening in every day. And just to finalize, our challenges in terms of what's in the future. I think that if we want to improve our healthcare systems, we have to focus on four main issues. They have been recorded and said by Sylvain before, some of them. Health promotion innovations in models and approaches. You have to take into account social determinants of health, the life course approach, focusing on population health, and engaging people, business, and healthcare institutions. So health promotion is one. Second, you have to reorient the model of care, and that means that we have to go to people-centered care, healthcare at homes, health and social integration, networks and multidisciplinary health and social care partnerships, and of course, personalized and predictive care. Third, we have to change the management paradigm models. We have to go into a value-based healthcare model. Outcomes and experience measures have to be in the center of the decision-making process in the managerial, the management of the healthcare system. We have to empower patients and make them more capable on making their own decisions. Patients are making most of the decisions already. They decide whether they go to the accident and emergency department. They decide whether they take their pills. They make a lot of decisions. The problem is that we must make sure that those decisions are integrated into the overall decision-making process of the system. So, and of course, achieving the best results. We have to include them also in the co-design and co-production of the system. We have to make sure in this new management paradigm that professionals, managers are accountable for their decisions, which nowadays they are not. And the fourth idea is the sustainability of the system. That means that we have to include the new ideas of the new economics of organization of the Nobel Prize, William somehow, the theory of contracts and whatever into the analysis of the health system, which is not normally. We have to develop new ways of funding and contracting based on integrated care and, of course, based on outcomes. And we have to redesign all our standards, accreditation and regulation systems, and we have to research on that. And to finalize, I think that the European projects have been very useful for us. Of course, they have not changed the health care system in the Basque Country, but they have been a catalyst for the change. So I think that's, please go on. I would only recommend that you develop a new funding tool so that data that have been obtained from projects that have finished can be further analyzed, because this is one of the problems. The projects are too short, and we end the project with just enough results to satisfy the contract with the EU, but there could be much more profit out of those projects if there would be dedicated funding tools just for an analysis of those data. And of course, I would insist on the benefit of the partnerships like the EIP on AHA, for example, that have allowed us to have a more horizontal and barrier-less kind of contact, not only with the Commission, but with different kind of stakeholders. The system is industry, which normally you don't have this kind of contact because you are negotiating with the Commission, you are under procurement process with the industry, and it's not so easy to talk freely. And this partnership have helped a lot. And that's all. Thank you.
So I'm now skipping through your slides until we come to mine. Yeah, there we are. Okay, good morning. I was asked to talk about science-based evidence building and especially about the lessons that we have learned in the Selfie project. And I think I'm missing one. No, this is the first one. Okay, so we were all given 5 minutes, so I'll try to be as brief as possible. Selfie is an Horizon 2020 project on integrated care programs for people with multiple morbidities. It's about service delivery, it's about financing, and it's about measuring the performance of these programs. And such a big project has, of course, multiple aims, but the one that is most relevant for today's talk is the third one: providing empirical evidence about the impact of the integrated care programs and their financing schemes on outcomes using a method called multi-criteria decision analysis. So what lessons did we learn from the Selfie project? Well, first of all, that there are several good person-centered integrated health and social care initiatives that respond to the needs of vulnerable people with multi-morbidity. We studied 17 of these initiatives from 8 different European countries, and we grouped them into 4 categories. We had population health management programs with specific elements for people with multi-morbidity. We had frail elderly programs. We looked at programs for persons with problems in multiple life domains, so not only health problems, but for example, financial problems or housing problems. And we had programs for palliative care and cancer patients. And all of these initiatives or programs are really there to stay. They are currently operational. They have been operational for several years, and they will most likely be operational in the future. What these programs have in common is that there are relatively complex, multifaceted interventions, which mostly include reforms in each of the 6 domains of what we call the Selfie framework that we made. So domains like service delivery, leadership and governance, changes in the workforce, in the financing and the payment, in the technologies and medical products used, and in the information and research. And these interventions target multiple levels in the system. The micro level, where the patient and the doctors and the nurses interact, the meso level, the organizational level, and the macro level, so the national or regional system level. And these interventions interact with each other. And they are also continuously improved and adapted to the context. That adds to the complexity of these interventions. So what's even more important about these types of intervention is that their impact really extends beyond the health outcomes that we are usually including into a quality-adjusted life years. So it will not only need to measure health outcomes, but also well-being kind of outcomes, or experience with care outcomes, or reductions in productivity loss, or improvements or reductions in the burden of informal caregiving. And that's what we did in the Selfie project. We defined the core set of 8 outcomes, which we measured across all the 17 programs. So we did not only measure physical functioning and mental health, but we also measured well-being outcomes like social participation and relationships, resilience, enjoyment of life, and we measured experience outcomes like person-centeredness or continuity of care. And of course, we looked into the cost aspect. Additionally, apart from the core set, we measured productivity issues and informal care burden. And we did not only measure these outcomes in the 17 integrated care programs and in their usual care counterparts, but we also weighted the outcomes so that we could in the end combine the measurements with the weights into a sort of overall value score. And apart from the core set that we measured across all 17 programs, we also had a few program-specific types of outcomes, like, for example, for the palliative care or the cancer care programs, the time between referral and start of treatment. So that's just one example of a program-type specific outcome. So what we demonstrated in the SELFIE project is that it is possible to apply evaluation methods that capture really these broader societal benefits. And that it is also possible to apply scientifically sound, non-randomized, but still controlled quasi-experimental study designs. We had many different types of control groups. For example, a control group from a different region, or a control group with patients who were insured by a different health insurer, which did not offer the integrated care program, just to mention two. So in terms of the results, what did we find? Across the 17 programs, there were many programs that were really able to statistically significantly improve person-centeredness and continuity of care, so measurable improvements in these patient experience outcomes. But when we looked at the difference in the overall value scores between the integrated care programs and the usual care programs, we saw that those were generally driven by improvements in enjoyment of life, which was the highest valued well-being outcome across all 8 countries in the weight elicitation study that we did. And we even found that some programs were able to demonstrate net cost savings, like, for example, the palliative care program in Hungary, where they had a mobile palliative care team, which moved a lot of the palliative care out of the hospital into the home care setting. So my last slide, we studied the 17 case studies in great detail to try to understand why their implementation was sustainable. And we identified 10 mechanisms that contributed to sustainable implementation. And we put them into this framework. And I cannot list them all, but just to give 2 examples, we observed that across the 17 case studies, most of them adopted an incremental growth model, so expanding the scope of their program over time. And many of them also applied some kind of distributive governance. So there was not one leader, but at different levels in the systems, there were clear people appointed with clear responsibilities for aligning all this work. The overarching mechanism of implementation was that the implementers were constantly engaged in trying to align all the different aspects and components of the programs at the various levels of the system. And we think that these 10 mechanisms are really applicable across different local, regional, and national contexts. So thank you very much.
Well, thank you very much. Thank you very much to the panel member, to the panelists here. We think we have already a very long list of success factors through all the different interventions here. I actually taken notes of a very long list, and it's very interesting to discuss that. And we're going to take that also in our own work in the Commission on the way we will make proposals in terms of taking that forward. What I think we should do now is give you the possibility to have your questions answered by the panel. So we have a number of questions that have been, and I'm discovering with you now, that have been rated by the audience. So the first question, I guess, is... So I read it as it appears on the screen. How should we measure health systems going forward? Currently, many measures are process-based, for example, waiting times, but this inhibits innovation involving process change. How should this change to encourage innovation? We just heard from Maureen a certain number of experience in relation to measuring value and the overall value. I don't know if that's a starting point for the answer. Would you like to, or would anyone want to address this particular question on what new data, new measurement we need to be able to actually better measure the improvement for health systems?
Yes, what we actually want to know, of course, are real outcome measures, patient-reported outcome and patient-reported experience measures. But patient-reported measures, collecting those information is time-consuming and involves a lot of efforts. It's not easy to collect those on a routine basis. But since we have an increasing number of easy-to-use e-health and m-health applications, we could start using them in routine practice and ask patients routinely at certain intervals to reflect on the care that they are receiving. That might be one way forward.
Do you want to?
Yeah, but
You go ahead. Oh, well, okay, we're fighting over it. Yeah, so if we go back to the World Health Report 2000, what are the goals of a health system? And they're improving health outcomes, fairness of financing, and responsiveness to legitimate expectations. I would argue that we do now have a good way of comparing outcomes. The Health Access and Quality Index from the Institute for Health Metrics and Evaluation in Seattle. I would say that because they do use as their basis the Nolte and McKee measure of amenable mortality, which we developed, which we were delighted to see. But I think that is actually focusing attention on outcomes. I think you can do quite a lot with PROMs, patient-reported health outcomes, because in the United Kingdom, or in England anyway, there are now a number of professionally led registers, and the Royal Colleges have really taken ownership of this and have got a lot of systems in place. But I think this is an example of where this can work if it is owned by the people who are actually delivering the care rather than imposed from above or from outside, because and also it is difficult to translate across different European countries because of the differences in the structure of the representation of the health professionals, which are very different. You know, you can't really compare a Royal College in the UK with an Arts and Kammer in Germany or Ordre de Médecins in France. They are quite different. And then the second bit is fairness of financing, and the work that the Barcelona office of WHO have done on out-of-pocket expenditure and shown that actually even in countries in Europe that have universal health coverage, a lot of people are paying a lot of money for medicines, for dentistry, for some other things. So I think there we need to make much more use of those. And then that takes us to the agenda that was set out in Tallinn in 2018, which was include, invest, innovate. And I think that sets out an agenda for how to do this, encouraging innovation, encouraging inclusivity, but making sure that you do actually promote health outcomes. So there's a lot going on there, which I'll leave for other. You know about most of it, but I think it's important that it's probably all better known.
just to add one thing, I think it's very important, this value-based evaluation based on PROMs and PREMs. But I would add that the same as we were talking about bundled payment for integrated care, we should talk also about bundled evaluation for outcomes. Just an example, when we started with the congestive heart failure program, integrated care program for congestive heart failure, what we found at the end of the day was a very successful decrease of the number of admissions to hospital of those patients. But of course, what we got was a biased type of patients being admitted, ones that were more severe. So the outcome measures in hospital were more mortality and more healthcare consumption because there were more severe patients. So if you do not evaluate the whole integrated care also happening with the old patient, all those patients that did not get admitted with the new program, instead in primary care, you would get a very biased view of the success of the program. So you have to have integrated evaluation also.
Okay, well, I understand, I'm looking at my colleagues that I can't see, that we have a bit some flexibility with the time. Do we have like, what, how many more minutes? 2 minutes? Well, if we only have 2 minutes, I'm afraid we have no flexibility. So what we need then to move on is to, well, I thank the panel for their intervention and for the very good input. And now we're going to hear a bit from you through the tool again and ask you 2 questions. The first one is how you think a collaborative effort at EU level. Can we have the question put on the screen? Yeah. What sort of collaborative, or what should be the focus of an EU-level collaborative effort as part of Horizon Europe? Are you getting the question in the app? What kind of operation could be fostered by the EU Horizon Europe? Collaboration platform to bring together relevant public and private stakeholders, design of new methodologies, tools and models of care allied to implementation research. You can vote for several of them, I understand. Is that true? Yes. Establish the conditions for transferability and upscaling of innovative health and care solutions. It's moving. So you can pick up more than one. So let's wait. We reach maybe 20 or 25. So clearly this idea of collaboration that we have heard here, the partnership, the need to involve, to listen to patients, to listen to professionals, the need to involve the key decision makers in the process of innovation, the need to convince about the effectiveness and the value of the process and so on. So this is also coming up as a key element, as if I understand well what you're telling us through this, this first question, first conclusive question. And the second of this conclusive question is the following. It's so now we're looking more in details about the type of operations that could be considered to support the strategic approach that we've discussed in the session. So what are the Rni priorities that could be tackled in the EU joint effort? Better use of health data for foresight and planning of national regional budgets. So for policy making, I guess. New models of care, integrated care, primary care, disease prevention, health promotion. Translation of best practices and financing and reimbursement of healthcare services and products. We've also heard that. So new models of contracting, new models of procurement, new models of financing. And that's it. So there again, you can pick up more than one. And probably they're all related to each other in a certain way. But clearly, we have to finish, I'm told. Oh, I have 5 more minutes, so I'm going to tell you about my holidays. No, this will be 5 more minutes to conclude on this. I think we're getting a very good picture. And I will ask, in fact, my colleague, Pilar, who's been following and listening very carefully to everything that has been said, to tell us a bit about the main important messages that she thinks we should take from the meeting, from the conversation.
Thank you. Thank you very much. Thank you, everybody, first, for being here today, giving us your views on this event, on the European Research and Innovation Days. If you were here yesterday at the inauguration, at the opening speech of the Director General, he mentioned something quite important that I want to repeat. The research, this European Research and Innovation Days is for us an opportunity to listen, an opportunity to co-design with you, our stakeholders, the next framework program for research and innovation. We didn't come here to talk. We came here to listen to you, to your needs. So I've been very attentively taking notes, and I would like to encourage you to help us again with this co-design. Please remember that there is an open consultation striving at getting the views of everybody on this framework program, the strategic planning. This open consultation still on the web, accessible on the web, and will be open until the 4th of October. If you haven't done it, please go there and express your views. It's dramatically important to have everybody's point of view in there. We're looking really at new stakeholders beyond our classic constituencies. So make the difference, please, because we're here to listen. And of course, we have heard a lot of important points in here, but maybe if I can just wrap up my very preliminary conclusions. We will work them better, of course, with the time. But it's I've heard that there is really a strong call for evidence-based to help move from the more classic healthcare system into the future healthcare systems that we're going to need, taking into consideration the evolution of Europe and the world. But this evidence base cannot be happening in a non-structured way. We need to foster this structured cooperation, and we have to have a more embracing, more systems thinking, where a global research on the challenges which are global can then be adapted to tailored solutions that can be then implemented. But this won't happen if we don't bridge the gaps between the communities, I would say both horizontally and vertically, meaning across Europe, but also across the healthcare system in the sense of involving and engaging with all the participants, all the stakeholders, all the interested parties. And if we don't get the engagement of all and we don't get the ownership of all, this will not happen. So scaling up or embracing this change, it is a matter for all of our constituencies, being it researchers, being it healthcare professionals, being it patients, being it public funders, as we are, being it health organizations. There is a call that I've heard about a way, maybe structured way, to go into, say, a partnership or some kind of association of interest where we can all work together, learn from each other, and make this change happen. It's a very rough, very, very preliminary conclusion, but I hope I have captured most of what you have said. And I just wanted to thank you all for this intervention and very interactive session.
Thank you. Thank you, Pilar. Thank you to the panel. Thank you to the audience, to the colleagues that organize this, Lucianos and Anna in particular. And before we close and you are able to move to other events today, I would like to ask you to, well, first I have to tell you that if you're interested, you can continue the conversation with Commission colleagues that are available in the village, in the health home 8 and 9 it's called, so you can find them there. Also, as you are leaving the room, you can again use the application to rate the panel or to rate the event or the session, so that you will find in your application. Thank you very much and have a very good day.